Well, welcome everyone. It's a great pleasure to have you here for our Thursday afternoon colloquium. And today it's our honor and pleasure to have one of our own coming back. So I just had a great discussion with Tom up in my office, and Tom got his PhD here at OPSI 27 years ago in 1991, working in astronomy and remote sensing, doing infrared work jointly under Jim Burke, but also with his supervisor being George Reiki, and many of you know George. So today, Tom is a professor. He's the Joe King Professor of Engineering at UT Austin, and has done an incredible body of work in biomedical optics. And he's going to talk about that with us today, and in particular a lot about his work on optical coherence tomography. Something he probably won't be weaving deeply into the talk, or maybe he will. Is we had a great discussion on how much of an entrepreneur Tom is as well, and many companies that he started up in and advised, and many of them have been quite successful with intellectual property and products, and one of the metrics is just an incredible number of patents, 55 U.S. patents. So that's something to be proud of, in addition to lots and lots of publications in book chapters. And Tom was honored as inducted into the National Academy of Inventors recently, and also in the American Institute of Medical and Biological Engineering and American Society of Lasers in Medicine and Surgery. So it's a great pleasure to welcome Tom to give his talk on optics for medical diagnostics and surgery.
Thank you. Thank you. Well, it is a real honor to be here. It's been a long time since I graduated, so today I'm going to try to sort of weave together what's happened in my career over the past 30 years since leaving here, together with sort of bring it up to date to what I'm doing now. So outline is, I'll sort of give a real brief storyline of what happened to me after graduation. I'll talk a little bit about, in tissues, one of the big concerns is, if you're going to image, how do you get around the scattering problem? Okay, and so the technology optical coherence tomography really uses a very old principle of optics, coherence gating, and is being used in many areas of medicine today. One of the areas of research that I got started in very early when I went to Austin was to try to use optical coherence tomography for early diagnosis of glaucoma. And that work has sort of evolved into looking for neuropathies in the retina. And I'll talk a little bit about that. Another area that I started working on in Austin was coronary artery disease, myocardial infarctions, and could you use optics to image inside the coronary artery and maybe see these lesions that might be susceptible to heart attack. And there's a real interesting story there. And more recently, we've been developing artificial intelligence to try to better interpret those images. And then finally, I'll talk about some more recent work on using image-guided surgery. So here's sort of the storyline. I was here in 1986 through 1991. And then I went to the Beckman Laser Institute from 92 to 97 in Irvine, California. And then I've been in Austin for about 20 years. Some of the highlights, as Tom said, my advisor was Jim Burke and George Reiki. I did the work in astronomy. Jim was sort of the mentor, and it was sort of a strange situation. Jim's expertise was in fibers, and I somehow, Frank Lowe, who was a professor in astronomy, gave a talk just like this, and he talked about IRAS, the infrared astronomical satellite. I was so inspired, I actually went over to astronomy and says, hey, I want to work in this field. It just turned out they were able to give me a position. So I did my dissertation in the design of far infrared detector arrays. What did I do here when I was here? I used to like to ride a motorcycle and go hiking in the Catalinas. I probably wasn't the best graduate student as if I was a professor for myself. I probably was not as good as I would like some of my students to be, probably. And probably the most notable thing was I got married when I was here. I met my wife in plant sciences, and she just happened to be teaching, and I was in the class, and we ended up getting married. So at the Beckman Institute, I worked with Stuart Nelson. My focus was on trying to come up with a better laser treatment for these birthmarks or port wine stains. Major accomplishments there, we developed this cooling methodology that turned out to be very successful, not for port wine stains, but actually for laser hair removal of all things. And that sort of shows the vanity of human beings. And then we also developed some of the angiography techniques. And so most notable event in Austin is we've got our 2 children into college, and mostly through my daughter will graduate this spring. And most of the focus in Austin of my work's been in the eye and the heart. So the promise of light medicine is, for surgery, is that we all know light can penetrate into tissues without necessarily having to make an incision or a big incision. So, you know, the promise is if you can get the light down to where you want it to do its work, you don't have to make a big incision. And that's a huge advance, right? On the diagnosis side, we all know that light has this incredible bandwidth, and the size of the wavelength is just perfectly suited for imaging things smaller, cellular size, right? Cells typically 10 microns. The wavelength of light that we work with is typically 1 micron. So it's like a real match there. So laser surgery today, and I'll sort of go through quickly some of the work I did at Beckman, was really initiated by Rox Anderson, who's a professor at the Mass General Hospital in Boston. And you can kind of think of it as magic bullets. So you inject the light into tissue, and the way you might think, well, how am I going to get the light down to where I want to get it to do its work? Well, the way it works is you inject the light into the tissue, it scatters all around. But as long as the wavelength of the light is matched to whatever your target is and where it absorbs at, it will absorb that light. And if you can adjust the dose and the pulse duration right, you can go ahead and destroy that. So just quick backgrounds. The major absorbers are proteins in the UV. Then there is hemoglobin and melanin in the visible, and then water in the infrared. So those are the major components that absorb the light. So the first project I worked on at the Beckman Institute was, as I said, the laser treatment of port wine stains. And these are birthmarks, and it sort of shows what happens to a patient as they grow older that have these birthmarks. And you see they sort of start innocuous when the person is young, but they get pretty gnarly and nodular looking as the patient gets older. So the effort is to try to somehow treat these patients with lasers. And so the way it works is the laser light goes in there, and the wavelength is one that's absorbed by the blood. And if you kind of adjust the laser light right in terms of the pulse duration and the dose, you can essentially cook the vessel. You don't want to blow it up or break it. You want to sort of cook it. And that way it will, you can remove the birthmark. So there's a couple problems. One, we all have melanin on our skin, and the melanin essentially, the function is to block the light from getting deeper, right? And so if you're trying to target a blood vessel and the melanin's there on the top, okay, the melanin is sort of stopping getting that light. Now when the melanin absorbs the light, it heats up, okay? So you're heating the wrong thing. You're trying to get a blood vessel, but the melanin is not only blocking the light, but it's heating up itself. So the first real invention I was able to participate and contribute to was actually a very simple idea. And I was a researcher at the Beckman, and we were trying to think, we knew people had tried to cool the skin, but the trick is you got to sort of cool it very fast, right? Because if you cool it too long, you'll cool the blood vessels, then you're not gaining anything. So you got to cool it for a very short amount of time to get the melanin, but not cool it long enough that you cool the blood vessels. So we were thinking, and the original idea was very mechanical. We were going to have this window come down, touch the skin, keep it in contact for a certain amount of time. And we were at dinner one night, and Stuart Nelson is a baseball fan. He says, you know, when those baseball players get stingers, they take and just spray something and kind of numb the pain. Why don't we try that? And so my job was to actually build this thing. I thought, well, that's a lot easier than taking a window and having it come down and touch. So we did, and it turned out to be great. It worked super. And the CEO of a company just happened to be visiting Southern California, and we said, hey, we have this new idea. We'd like to show it to you. So he comes by, and we actually do it on his skin. And his response was, gosh, it takes the pain away. I want it. So again, what we'd actually developed the treatment for, or the methodology for, was to treat patients who had more melanin. You couldn't treat them very well. But the CEO actually licensed it because he said, hey, it takes the pain away, right? Well, then what happened is, of course, they licensed it, and what the cooling method really was used for was more hair removal, which, again, it was used for the vascular lesions and other treatments, actually many other treatments, but the treatment that it was used most often was hair, and that's simply because that's one of the treatments that is done most often in laser dermatology. So I'm going to talk a little bit about imaging and light scattering. You're probably familiar. You inject light into tissue. It starts scattering profusely. We've all taken your finger, put it in front of a laser pointer. You see that kind of fuzzball or blur. And so if you're imaging with photons and you really want to get good resolution and sharp boundaries, then you really have to catch these photons that go through very sort of the leading edge, either the ballistic or the snake photons, okay? And those are the ones that you have to get before you, to form an image. So the technology that actually just started coming out when I left OSC was this coherence gating, or optical coherence tomography, and it uses it was actually developed for finding faults in fiber optics. So time domain reflectometry could get a fault that was a long distance away, but if you needed fine resolution, the OTDR really didn't have the resolution. So this technique was actually well known in the fiber optics community, and it's essentially just using coherence gating. And so if you want to know where the light reflections have bounced back from these tissue boundaries, you just gate that with light coming from the reference, and you interfere them. And so it's a simple interferometric approach to sort of gate photons coming back. The light sources for OCT are kind of unique, though, because in order to get the gating, you have to have a broad spectrum or broad spectral width, because that gives a short coherence length, and that allows you to do the fine temporal gating. So you need a broadband light, and of course, most of you probably have taken coherence theory, and you see the Wiener-Knickheim theory there. But the other side is, if you want to do interferometry and not have cross-modal interference, you really just need one mode. And since most fibers are the 0-0 mode, you essentially need to have a single spatial mode, but a very broad wavelength. So one way of thinking about this in the spectral domain is, if you start with a swept source and you look at the interferograms for all the different wavelengths, at one particular path length difference, say delta Z1, this is one path length difference between these two, you'll get a fringe pattern that varies with wavelength, something like this, and this is the equation that describes that. If you go to a higher path length difference here, the fringe frequency just increases. So you gate these photons from different depths back by looking at the fringe frequency in the spectral domain. And that's sort of how OCT works today. If you're thinking about it more in terms of a spectrometer, you bring in the broadband light. It reflects off these interfaces inside the tissue here. And the bigger the path length differences are, if we go from a short to a long, that just changes the fringe oscillation on the spectrum. So it's just through the Wiener-Knickheim theorem, one can then find the interfaces just by doing a simple Fourier transform of the spectrum. So that's kind of the basis of OCT. It's actually, as I said, been known for 100 years at least, and then actually was practiced in the fiber world and then brought into biomedical optics about 30 years ago. So next I want to sort of shift to the retinal work. And the eye, as when we're growing our mother's womb, the eye is really an extension of the brain from the very beginning. So there's a huge emphasis now on neurodegenerative diseases and aging and so on. And the eye is absolutely the best place to look because it's easily accessible. You can get right at the brain by looking at the retina. So it truly is a window to the brain. And the idea of using OCT, again, here's sort of a histological cross-section of the retina. You can see these different layers or these interfaces by simply using OCT to gate those reflections back. And here's some images that have been recorded in my lab and others of retina, right? And so the top left is an image we recorded probably 15 years ago of an actual primate retina, but you can clearly see, you can see all the different layers of the brain from the retinal nerve fiber layer, which is the topmost layer, all the way down to the choroid. You can also do what's called angiography, where you look for little jiggling of the fringes, and that usually represents something's moving, and that something is typically blood. So you can map out all the vasculature in the retina and see, really, it's just astounding. It's become the standard now in ophthalmology for imaging the retina. So recently, there have been a couple very recent reports that describe just the idea of using OCT to get an early idea of neurodegeneration. And one of them is, again, looking at the thinning of the retinal nerve fiber layer, which is this topmost layer right up here, this layer here, or you can sort of see it here. Here's the RNFL here, and then over there you can barely see it. But so as there's a cognitive decline, that starts to thin, and that's been observed in almost all neuropathies. That nerve fiber layer actually starts to thin. So when I first arrived in Austin about 20 years ago, our idea was to use polarization-sensitive optical coherence tomography to try to see degeneration of that retinal nerve fiber layer even earlier. So before it thins, could you see the fibers sort of start to lose their birefringence? And so we could still see the thickness, but if we could maybe get a measure of the birefringence early on, we might get a faster, earlier read on neurodegeneration. So we used polarization-sensitive optical coherence tomography, which, as you could understand, just uses polarized light, and we actually want to measure the retardance of the retinal nerve fiber layer. So we built up this fiber system here, and basically consists of the source, simple interferometer. Here's the reference path, and then it uses this sort of complicated balance detection approach over here. And then the other element here, this is a clock, because when one reads out those fringes in the spectral domain, you have to make sure that they're timed or they're sampled exactly at the right frequencies and you know those frequencies. So we built that system. This is a picture of my graduate student who helped build it, and the rat's nest of fibers in there, looking into it. So it's a simple slit lamp. The patient just puts their chin on the chin rest, looks in there, and then there's a sort of a staring beam to make sure the eye stays stationary while the measurement's being made. And we actually did a fairly large clinical trial testing this idea. Could this methodology see patients early with glaucoma? And so, these are some of the images we recorded. So this is a map of, say, the left eye and the right eye. In this particular case, this is actually the retardation, the birefringence, the phase delay between the two polarization modes in just the topmost, the nerve fiber layer, for different positions. And we sort of put the blood vessels on top just to make sure they weren't interfering with the measurement. And so those are the two eyes. You can measure that out. You could even, with a little bit of processing, you can even determine the fiber direction, because the axis of the fibers is the retardation axis of the birefringence axis, so we could map out the fiber direction and really get a lot of information out of this. But the storyline, what we found is that what changes first, even before the birefringence, is just simple light scattering. So the tissue actually starts to structurally modify itself where the light that's being backscattered from the nerve fiber layer is less. And that occurs well before we could see any major changes in retardation. So that was about 10 years ago. So we had to take a step back and say, what's this all about? And so we looked into it and found that almost all neuropathies have a connection with the mitochondria. The mitochondria, of course, are like the little batteries in our cells that provide us all of our energy. And it's been known since Britton Chance was one of the sort of fathers of biomedical optics. It was at Penn, a pretty amazing person. He actually competed in one of the early Olympics, and he developed the pulse oximeter. Anyway, it's been known since the days of Britton Chance that mitochondria, especially in tissues with high metabolic demands, that mitochondria are a big component in the light scattering. Okay? And so what mitochondria do is they go through this sort of fission-fusion cycle where they fuse together, and mitochondria have their own genes. They actually trade the genes and try to keep their gene pool up, okay, and then the bad genes go in some mitochondria that then just get taken away by macrophages, okay. So we suspected, because the retina is one of the most highly energetically demanding tissues in the body, right? It takes a lot of energy to see, that the neuropathies that have been observed might have something to do with the mitochondria. And because mitochondria are known to scatter light so strongly, we sort of hypothesized, okay, well, maybe if we can look at how light scattering changes direction, we might get a better read on seeing these diseases early on. So we took that same OCT system, and in the sample path, we did something very simple that most of you should get clearly understand. We just put in a Fourier plane a simple glass plate with an aperture in it. So now, when the light goes through this aperture, there's really 4 possibilities, but 3 different path lengths. Like the light can come in the narrow part, come back in the narrow part. That's kind of low-angle scattering. It can come in through the outside, come out through the middle, or it can come in from the outside and stay on the outside. So by doing this, we've sort of established 3 different path lengths for the light to go. And then when we read out our OCT signal, now we get 3 images. Okay, so instead of having just 1 image, we have 3 of them, and those correspond to those different light paths. Okay, and so you don't get it really for free, but it's not much work to have a little aperture like that, put it in the right place in the system, and get your images. So now we can start looking at the relative size of these low angle versus low high angles and so forth. And so we did that and actually did a small patient study and found that there were variations in the retina that actually correlated to the known physiology of the nerve fiber layer. Okay, the density of retinal ganglion cells and so forth sort of followed what we were seeing. So more recently, we developed a Alzheimer's mouse model, which is basically a genetically modified mouse that develops many of the symptoms of Alzheimer's disease. And this is sort of the timeline of the mouse from birth on out to about 1.5 years. That's typically how long they live. And these are some of the changes that are observed in this particular mouse model. You see the plaques just like they're observed in people. There's cognitive impairment, these neurofibrillar tangles, and so on. So this is a model that's often used in Alzheimer's research. And so my graduate student, modified an OCT system to image a mouse eye. Okay, and so this sort of gives you some of the specifications of the system. Some of the unique features of it, it used a MEMS micromirror, and then, of course, we had to define the optics. He actually made an optical model of the mouse eye and then designed this system to image the mouse eye. This is what it looked like. On the left is a CAD drawing, and then the actual system is shown here. So the light comes in here, and this is where the mouse goes. Right, the mouse eye goes right there. And so it's not shown here, but there's an actual mouse holder that is then positioned right up against the lens there. So I'll just quickly show the results. So we can also do the angiography in the mouse eye. Mouse eye is much harder to image than a human eye, but you can sort of do this depth resolved imaging. These images here shows a color code of the vascular as you go through the different depths of the retina. So you can pretty much see the whole vasculature of the mouse retina. And then just like before, you get these three images. Okay, so you get the low, 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 high, high, high images. And you can start looking at ratios between the amount of light that's scattered in, say, a low versus high angle, and then look at how that ratio goes. What the student found is that ratio actually fits this Burr distribution very, very well. I know it's a complicated slide, but here's a Burr distribution, and for all the control mice, there's three parameters that control the Burr distribution, but the fit was just very, very good. And so we sort of excited and said, okay, somehow this distribution is capturing the statistics of the ratio of the low to the high-low scattering. So just kind of what we found is that if you look at this one parameter of that Burr distribution, the C parameter, which is sort of how high it's peaked, and we look at the control mice versus the Alzheimer mice, red versus blue, we see there's a fairly large difference when the mice are very young. But as they age, that difference starts to shrink. So it's basically saying that as the mouse ages, even if it doesn't have the Alzheimer, it starts looking like it has Alzheimer's, more like the Alzheimer's mice, okay, than when they're young. Okay, so when they're young, you see a big difference. When they both age, you see a smaller difference, which is kind of interesting. There's been some recent studies, actually. There's quite a bit of debate going on. Do people really understand what Alzheimer's even is? So there was a large drug trial that was tested, and it was basically designed to prevent the plaque formation. And it was found, this article in the New England Journal of Medicine, that basically said that these plaques may not even be truly indicative of Alzheimer's. So this is something you find in the biosciences quite a bit. People sort of all think one way for quite a while, and then lo and behold, it comes back, oh wait, it seems like we were thinking about it wrong. So it's not really clear what Alzheimer's is now, and that's a topic that's being debated. So what do we know? Most neuropathies, almost all neuropathies, have a retinal manifestation. Okay, and people have seen this in looking at cadavers, people who have died, and so on. So mitochondrial dysfunction is associated with almost all neuropathies. We know that mitochondria have a big component in light scattering. And I guess the takeaway is, OCT, because it involves these spectral sources with essentially enormous information carrying capacity, there's all sorts of ways to multiplex the signal. The scattering angle was just one of them. You could increase that by 10 times. So the enormous information carrying capacity of OCT provides many opportunities for early detection of neuropathies in the retina. Okay, cardiovascular disease. This is unfortunate, killer. We'll all probably be familiar with someone who's had a heart attack. My father had a heart attack actually when I was here as a graduate student. He's still alive. Got good treatment. But it's a huge burden on our society. Millions every year. So what is a heart attack? Well, if we look at the heart, there's 4 main coronary arteries here. The right coronary artery, the left descending, the circumflex, and then the left main, kind of behind the, right back there. So what actually happens in most heart attacks is there's, this is actually a patient who died of a heart attack, and you can see this junk that came out. So what happens in our coronary arteries, and we actually, it's known now, we all develop these things, even younger people develop these to some degree. And there's oftentimes these what are called thin fibrous caps. And inside those thin fibrous caps are kind of a mishmash of stuff. I kind of think of it as like a pimple on the inside of your coronary artery, right? And so there's lipid and all sorts of junk. And when you subject your coronary artery to high shear stresses, so like if you haven't been working out or doing exercise, and all of a sudden you say, oh, I'm going to go run a marathon or something like that, you subject this to high shear stresses, okay? Then if it breaks, if it ruptures, then this stuff comes out, and that stuff is very thrombogenic, okay? And it forms a clot, and that's a heart attack, okay? So the idea of OCT was, well, if we could see these thin fibrous caps, so we go in there with a catheter and try to see those thin fibrous caps, maybe we could prevent heart attacks. That was the thinking. Okay, now as you'll see, it hasn't quite worked out that way. But I'll tell about that story. So we developed a system, endovascular OCT system. This is kind of a diagram. On the left is the console, and on the top there is a PIM. The PIM is what interfaces the OCT system, which is sort of inside here, to the catheter. The catheter is sort of diagrammatically shown here. So you plug this catheter into the PIM. So this thing plugs into that. And then this little bead here, which is this, clips on to that. And then this PIM, it does essentially rotational motion and translational motion. And so there's an optical fiber that goes through this catheter here. Okay, and this is sort of shows the distal end. There's this radio-opaque marker, so when the X-ray comes down, it's absorbed. So it's, you can see it under the X-ray angiography. And this is kind of a close-up of the catheter at the end. So there's a torque coil, which is necessary because when you put a catheter like that inside the body, there's all sorts of twists and turns. And when you turn it, if it was more rigid, it would start whipping around. So these are sort of specialized torque cables. We always use a company called Asahi. Essentially, they're spirally wound wires that you can take and bend them in these really interesting configurations, and you turn it, and it will keep that configuration. So typically, these procedures are done where you go into the artery through the femoral artery, and then you go up around the aorta down into the heart, okay? And this is what the end of the artery looks like, or the end of the catheter looks like. So there's, again, another radio-opaque marker. There's a little aperture here to focus the light, and it's a fairly simple system. There was a ferrule, a Grin lens, and a prism, and you want to have the focus distance to be about the mean of looking inside the artery. So the way it works looks something like this. Let's see if I can get this here. So there's blood flowing. Okay, that's the guide wire coming in. Okay, the guide catheter, the guide wire was the wire, and then the catheter is actually over the guide wire. Okay, now that fluid is flush fluid. So this stuff, this is obviously a cartoon, is water or saline that has to be flushed through to displace the blood, because you can't image through blood, right? It's highly scattering. It's not so much its absorption, it's its scattering. So you got to remove all the blood, and then you're spinning that catheter, rotating around and pulling it back at the same time. And typically you'll be pulling back around 20 centimeters, maybe 40 at most. That's a typical distance. The catheter is spinning at about 100 revolutions a second, and it's pulling back. So you have this very limited amount of time that you can do this imaging measurement, right? Because you can't, you have a limited amount of material that you can inject into the body, and so you have this sort of short space-time window to get your image, okay? And this is, you know, sort of a cartoon of a plaque region. So we built this thing, and actually, I'll show an actual pullback. Okay, that's one of these places that could cause a heart attack right there. Had the thin fibers cap in the lipid core. All right, so that was what everyone was sort of looking for. That's what we wanted to see, right? And so what sort of happened though is like, okay, well, you see it, now what do you do? You know, and so as I'll describe, basically where this technology is being used today is mostly to help put stents in, or to look at how well stents are doing after you've put them in. Okay, so this is an example of sort of a post-stent imaging. And you can see the stents, they sort of show up as little bright reflections. So you can see how much tissue has grown around a stent. Which is like, okay, well, that's nice, but you know, here you can see it's a little bit thicker. But if we look at today, okay, in the United States and Europe, this technology has a penetration of only about 5%. And part of that is due to reimbursement, but part of it is most cardiologists say, hey, I wouldn't change my treatment. If I image this person, the chances of me changing how I would care for them are very slim. So I'm not going to do it. Okay, so like 1 in 20 cardiologists will actually do this sort of procedure in Europe and the US. In Japan, it's quite higher, but that's the way it is. So the lesson from that is that unless the treatment somehow drives the therapy, it's probably going to be used marginally. And that's the truth. And it kind of makes sense, right? You got to benefit the patient. And okay, if you see more, but what it takes to just see that and you can't connect it with the treatment, it's questionable. The largest, where this is being used is essentially to evaluate different therapies like drugs or stents or things like that. Okay, so these are like studies that are sponsored like by a drug company or by a stent company, and they'll use this technology to evaluate how well their therapy works. Okay, but it's not used like if you go in for a or you know someone goes in for some cardio problems, you're probably not going to get OCT. Moreover, there's 2 big studies that are ongoing, Prospect 2 and Prospect Absorb. They're not even using IV OCT, which is kind of a... So the question is, can cardiovascular diagnostic imaging provide a better pathway for therapy? And right now, it's unclear. Okay, I think eventually it will, but right now it's unclear. So I just want to take a few minutes and describe some work we've been doing to sort of follow up on that. And part of the issue is that, you know, you look at these images. Let me pull this image up here. You look at one of these images, and you know, you haven't seen these before. You probably say, I don't even know what I'm looking at. And I probably should have explained it better, but here's like the catheter, but here's the artery wall, right? And I said, okay, there's a stent. But what, you know, do I know what kind of tissue it is? And I showed the pullback where I said, there's the lipid cap. How do you know that's a lipid cap? Okay, well, it kind of looks like one, but you don't really have any kind of spectroscopy of what that material is. You don't know it's lipid there, okay? So part of the limitation of OCT is it's really just more of a structural, the conventional OCT is more of a structural imaging modality. It doesn't really have any material information in it. You have to infer the material information from the structure. So what we did is said, okay, well, can we somehow teach it better? And so we have been developing these neural nets. We actually take human hearts from people who've died and image them. So this is one of the setups here, okay? And we actually bring in the catheter, image the coronary arteries. Okay, this may sound a little strange, but this is how we do it. So we image them, we get the OCT images, then we take and extract out that coronary artery. We do histology through the whole coronary artery and try to line up the histology with each OCT image. So it's a very laborious task because oftentimes the registration is not straightforward. So we do all sorts of analysis on the A-scan profiles, the variation in the intensity, and we've developed these 3-layer neural nets to try to identify lipid, fibrous tissue, and calcium. So we can then take this image here and color it according to its components, be it lipid, calcium, or fibrous tissue. So calcium is white, lipid is red, and fibrous is green. We've done a lot of work on this. We've imaged over 50 human hearts. And the nice thing about this is that we have this data. And so we can, if we develop new approaches or new neural nets, we can always use the same data. That's sort of nice. And so one of the first neural nets we developed, this is sort of some examples. We've got pretty good results in terms of the sensitivity and specificity for fibrous, calcium, and lipid tissues. And these are just some examples here. The OCT on the left. And then here's experts. Now, what normally people do is you have the practitioners and certain people who are considered experts. And they just look at these images from a real live person, okay? And they say, this is, well, I don't see a good example of calcium here, I guess down maybe, up here, yeah, right here. So they say, that's calcium. Well, how do you know it's calcium? I've seen it 1,000 times. I know it's calcium, okay? So the purpose of this was to do the histology and say, okay, no, we know it's calcium, okay? And if we do enough hearts, we could train this neural net to identify these different tissues. Okay, now this could also be used with optical coherence methods that have better contrast. But it's a first start, and we've actually, this was our sort of first foray. More recently, one of my students has developed a convolutional neural net that really is pretty nice results, and so we'll be publishing that soon. Okay, the last thing I'm going to talk about is the image-guided brain cancer surgery. This work is motivated by brain tumors. There's 2 types, the medulloblastomas and the meningiomas. They're very difficult tumors. And in fact, the model I'm going to show you probably isn't the best model for them, but this is normally what a person would call an inoperable brain tumor. So the idea, though, is when a person has a tumor, here's an MRI, okay, when the surgeon's in there trying to cut this tumor out, oftentimes the tumor will be adjacent to what's called an eloquent structure that might affect hearing or motor function. And so the surgeon has to be very, very careful in where they're cutting. And if they don't know the boundary here, and oftentimes when they go from this MRI to the actual surgical suite, almost always that registration is lost. Okay? And now OCT could help here because if we could see these margins, okay, between the tumor and the normal tissue, then a cut could be made at the right place. Okay? And what they do now is they try to register, do the imaging, say with MRI beforehand, and then try to line that up. But it's a problem, because if you're off by just a couple millimeters, you can be cutting into a motor area or something that would really adversely impact the patient's life. So this is a system that essentially the purpose is to do simultaneously angiography, which is imaging the vasculature, as well as the tumor margins. Okay, and so the idea is to coagulate the vasculature and then cut out the tumor. You have to coagulate the vasculature first, because if you start cutting without coagulating, you just get blood all over and you can't see what you're doing, and the patient is going to lose a lot of blood. So the first system we built looks something like this. It's actually very simple. It's an OCT system, the standard Mach-Zehnder interferometer going to the sample path, and then we have a coagulation laser and a cutting laser. Now, we're playing around with different choices for the cutting laser and coagulation laser, but I'll just show this for today. So these are some angiography images. So these are recorded of, these are 3 mouse brains here, and you can see the vasculature sort of coursing. You can kind of see in some cases where the tumor is, like right here. You can see how the vessels all kind of come in. Here it's probably here. Now, we can image the tumor separately, but you can kind of infer it where it is from the vasculature. Okay, so here's another case. This is just the standard en-face OCT image. Here's looking for the vasculature, and here we're looking for the jiggling of the speckles. And then this here shows a region that has sort of an anomalous attenuation, that attenuates the light differently. And so we can back out where the tumor is from how the light is attenuated. And so this shows, of course, OCT is a cross-sectional technique. So we're projecting these as en-faces, but they're actually depth resolved. So here's the tumor right here, and this was deduced from how that light is attenuated when it goes through that region. Okay, and so we can measure the size of the tumor. Now these tumors were injected in the mice by actually bringing a needle down and putting the cancer cells down at the base layer here. And what we end up seeing in most of these tumors is the cells grow up and sideways. Okay, and so we can see both the tumor as well as the vasculature. Okay, this just shows sort of a 3-dimensional rendering of the tumor. You can see this green, it sort of goes up into the needle track and then kind of comes out this way. And this just superposes the 2 images. The top image up there is a confocal, which is, you get a much shallower, it's a confocal microscopy image of the vascular using indocyanine and green. And you get a much shallower penetration. So the OCT will get you down to about 2 millimeters, whereas the confocal will stop around a couple hundred microns. So then you have to coagulate the vasculature. And the nice thing about this technique is, so here's an image that was targeted. This red circle was targeted, the vascular. So if we want to cut here, cut the tissue out here, say the tumor's down there, we have to first stop all that blood flow. But we have to kind of confirm that it stopped, or somehow know it stopped before cutting. So here we did the coagulation and then do a subsequent image and show that, yeah, we indeed stopped the blood flow. This is a sort of a color coding that when the blood stops, it mixes with the yellow and turns these regions red. So the red regions are sort of the regions that the blood flow has stopped. We can actually then measure, here's sort of a before and after, and then we can look at versus depth here, how much the fringes are decorrelated. So high decorrelation means there's a lot of blood flow because the speckle is speckling around as speckle does, so that would have a high decorrelation. And then after you do the coagulation, that decorrelation goes down. Now it doesn't go to 0 because you still have some residual motion. We know we truly stopped the blood flow because when we cut, we got no bleeding. Okay, it just shows though that you can measure that. Okay, so this is another another example. So here's the vasculature. Here's the tumor. You can kind of see the tumors in this sort of yellowish color. You can see it kind of growing up into the needle track here. This is sort of along the corpus callosum, and then it grows up into the needle track. Okay, and then this is after the coagulation. So we've essentially shut down all the blood flow around the tumor. Now we can go in there and cut it out. Okay, and so this shows one result of the a cross-sectional OCT. We purposely didn't try to cut out all the tumor because we wanted to leave some and see if we could see the residual tumor in the histology. Okay, and so and things match up pretty well. The size of the cut, the depth of the cut, the size of the tumor, left 0.65 versus 0.83, the depth 0.89 versus 0.84, and so on. There was some thermal issue here, and that's why this part here is sort of raised up. That can be addressed, but that's why that. And this part of the tissue that's sort of raised up sloughed off in the histology, and that's why that's a little bit different looking than it is over there. So here's just one other example. You can kind of follow from here's before surgery, here's the tumor, and then there's the image afterwards, cutting in at least to part of the tumor. Okay, so conclusions on this. You can do this simultaneous angiography and tumor imaging, and that can empower image-guided surgery. You can use the angiography to confirm you've got the stoppage of blood flow, so when you cut, you know you're not going to bleed, which is really important. The attenuation imaging allows you to see the tumor margins, and so you can cut and be sure that you're outside the margin and know where the tumor is at. So where we're working right now is to integrate this into a catheter, a small size surgical device, and I think we're making some reasonable progress on that. This was all a benchtop system that I've showed you, but the idea that the surgeon would have a device and they could use this in their hand or in a robot. Okay, so a few years back I read this book, some of you may be familiar with it, called The Innovator's Prescription by Clayton Christensen, and he sort of lays out a vision for the transformation of medicine in the next few decades, and it sort of takes up this paradigm saying that we're moving from intuitive medicine, which is kind of what the practice of medicine has been in the past. It's a great book. I really recommend it highly because it puts the transformation in medicine kind of in a business context. And he goes through a plethora of industries and sort of shows how industries always evolve through this sort of three-stage process. And it's computers, any industry you want to talk about, automobiles, they all follow this evolution. And so what this book does is he takes medicine and puts it in the framework of that evolution. And what you clearly see is, well, we've been practicing medicine, or I won't call it the business of medicine, but medicine has essentially been in stage one up to the present time. And that if we want to move to precision medicine, then the pathway is pretty clear. And imaging is an absolutely necessary component in that transformation. And it's an analogy would be, say, like the computer systems, right? When I was in undergraduate school, I would actually have my card deck, right? And I would program on my Fortran cards, bring them to the mainframe, run my program. That's like a stage one thing where there's one central user facility, right? And that's kind of like our big hospitals and these big centers where you all go to this one place. You don't, that's how you do it, right? And if you go to pay, okay, if you don't get healed or you don't get a good response, you pay anyway. It's called fee for service, right? And industries always start that way, where you pay no matter what the result is, right? It's kind of like lawyers or people say doctors because that's the way medicine is practiced. But is you move to stage 2, like in the computer industry, it was the PCs. Okay, there they gave, sold the PCs to the individual, and now it was fee for result. So if you bought a computer and it didn't meet the spec, you just go take it back and say, hey, this thing don't work. Oh, okay, we'll give you another one, right? Well, we're not there in medicine. There are some areas of medicine where if they don't work, you say, hey, it didn't work. Okay, we'll do it again or whatever. So anyway, this point here is just to simply say that I think optical diagnostic imaging and light and other based therapy are going to drive this transition to precision medicine. So I'm a big believer. So thank you, and I'll be glad to answer questions.